Welcome, everyone. Welcome to our virtual CU Anschutz Alumni Series, Happy and Healthy Hour. We're grateful that you're here with us tonight to connect with the CU Anschutz alumni community and to learn from our amazing community of experts at the Anschutz Medical Campus. I'm Marnie McKercher, and I'm proud to represent the CU Nursing Alumni Association. For those of you joining us who are alumni for the CU College of Nursing, the Alumni Association offers many opportunities to connect with your fellow alumni and current students. In fact, we are currently accepting nominations for Daisy Awards. We'll be providing more information in the post-event email to help you nominate a deserving alum or student. Our alumni office also has numerous ways for all alum for the campus to get engaged. Our alumni team is always happy to help connect you with activities for your college or school. We will share more at the end of this evening's event on upcoming events and how to reach the alumni team. Before I introduce tonight's expert, I'd like to draw your attention to the Q&A and chat function at the bottom of the screen. We will have time designated at the end of the presentation for a question and answer session with our presenter. Please enter one question at a time in the Q&A function, and we will be sure to address at the end of the program. Additionally, if you're using the chat function, please know that you can send your message to be visible to just the hosts or to all attendees. We have alumni team members available on the chat if you need anything during tonight's presentation. I now have the privilege of introducing tonight's speaker. Dr. Nanette Santoro has served as E. Stewart Taylor Chair of Obstetrics and Gynecology at the University of Colorado School of Medicine since 2010. She has led studies of women with premature and age-appropriate menopause, such as the Women's Health Initiative, the Cronus Early Estrogen Prevention Study, KEEPS, and the study of women's health across the nation. She is an active practitioner, has been named a 5280 magazine top doctor every year since 2016. She is a dedicated mentor and principal investigator of the Women's Reproductive Health Research K-12, co-principal of the Building Interdisciplinary Careers in Women's Health K-12, and principal of the Clinical Reproduction Endocrine Scientist Testing, CREST, program, R25 grant. She is a past president for clinical research for the Endocrine Society and was Mentor Laureate Award recipient in 2016. She has served on the Endocrine Society Nominating Committee, Annual Meeting Steering Committee, Government Relations, and Special Programs Committees. She chaired the Endocrine Society Scientific Statement on Bioidentical Hormones. She is past president of the Society for Reproductive Investigation and was elected to the National Academy of Medicine in 2018. Additionally, she is president-elect of the Endocrine Society. Please join me in welcoming Dr. Nanette Santoro, a visionary clinician, researcher, and advocate for women's health. And we are thrilled to have her with us today. Take it away, Dr. Santoro.
Okay, well, thanks so much for that lovely introduction. I hope I can live up to it in my comments here, but we're going to talk about my favorite topic, which now happens to be one of the hottest topics out there. Menopause treatment in 2025. So sometimes when you're a hot topic, it's fantastic because there's a lot of attention on the problem, and sometimes there's a lot of mythology that can grow out of the attention. I carry around a t-shirt that says science, because figuring things out is better than making stuff up. So what I am going to talk to you about are evidence-based issues and some of the things that are maybe not so evidence-based. These are my disclosures. I'm on the advisory board for companies that have non-hormone treatments for hot flashes, hormone monitoring kits, and treatments for obesity, and Anschutz measures ovarian hormones. So what I want to talk about are the stages of the menopausal transition, because I think there's plenty of confusion about that nowadays, but we have been doing research for about 25 years in the study of women's health across the nation, and we do have some pretty good data on when the transition happens and what the milestones are. Talk a little bit about hormone therapy. It's not the answer to everything. The mystique of testosterone therapy, which is often touted, has without a lot of evidence to back it up. So we can talk a little bit about that and talk about some non-hormonal treatments. There are actually some very effective new ones for women who do not want to take hormones or who cannot. So I'm going to give you my punchline at the end. If you want to go eat dinner early, this is what I'm going to tell you about. But this is a natural life passage. So medicalizing and turning it into a disease is not really the best way to deal with it. It happens to occur concurrent with aging, and it's not always very simple to sort out. No one needs to suffer with menopausal symptoms. And the proportion of women in this country who go untreated is pretty distressing. We are not doing a great job of reaching the people who have the worst symptoms, and we're not even treating the moderate to severe ones very effectively. Yet we do have a lot of effective treatments that are available. There's not just one size fits all. There's also tools that women can use. So you can use these yourself to understand where you are in your journey and what your symptom experience is likely to be and how long it's likely to last. And finally, again, hormones, they're good. They work like great for many women for symptoms, but they are not the magical tool that will prevent aging, which is a lot of stuff that's out there now in the social media sphere. So this is a simplified version of the road to menopause. And this is how you can kind of tell where you are in this process. If you are Jane average, you will begin to have your first skipped menstrual cycle at age 47. But you will have at least one period within the past 3 months up until you're about age 49. By the time the median age of 49, women will then enter what's called the late transition, where menstrual periods are 2 months to 12 months apart. So 60 to 364 days without a period. Once you go that long, you're closer to menopause. The median age at menopause is about 51.4 to be exact in the United States. And that is the most symptomatic period of a woman's entire transition. So we know that this late transition is when the symptoms really ramp up. They begin here in this early transition. And this is where it's a little bit tricky and where a lot of women are now kind of being given a lot of social media messages that if you don't feel great, it must be perimenopause. If you're 35 years old and you think this is happening, it's probably not the case, but it's not beyond credibility. It's possible. That early transition can last a long time, and it can start early for some women. So if it starts early for you, much earlier than age 47, the not great news is you're likely to have a longer transition. And because this is a period where hormones are in turmoil, a longer early transition means it's going to be more annoying and more symptomatic. So this is more variable. This part of the transition is more fixed. So once you reach that 60 days without a period, you're very likely to be done with the process within the next 2 to 4 years. 95% likely you're done within 4 years. So that you can kind of count on a little bit better. Unfortunately, we don't have good definitions for these stages of the menopause transition for women who have had a hysterectomy, women who don't get regular periods due to any other reason, and if you are taking hormonal contraception or you use an IUD and you don't get a period, then we can't really track where you are in the process using these kind of easy tools. We also know that women as early, and this is one study that shows women as early as age 35, these are 2,400 women who responded to an internet-based survey by my colleague Nina Kosloff, who has a website, and Nancy Woods, who's a researcher in Washington. So this is likely to be women who responded to the survey because they were having symptoms, but multiple symptoms were evaluated, and things that showed up in women within this age group were increased mood swings, brain fog, which is not a very specific condition, but is actually a common complaint, and women who have premature menopause and actually stop periods prior to age 40 will also complain of brain fog, fatigue, increased pain. So these are fairly non-specific symptoms. It's a little hard to pin these down to any one cause, and it's important to keep in mind they're not necessarily classic symptoms of menopause per se. There could be other conditions here that need to be worked up. So a hormone answer is not always the answer, but it is worth asking the question. Vasomotor symptoms, hot flashes, sleep changes, anxiety, depressed mood, those things are actually more tightly associated with the menopause transition itself. And there you can have a pretty good idea that your hormones may be contributing. One of the issues that came up in this survey and that I do hear from patients is that many women will struggle with having these symptoms off time. So they may go to see somebody and they don't get a validation of their symptoms. Could this be my hormones? Well, it could be, but many women are just told, no, there's no way, or that's impossible. So symptoms can appear early, but I would be a little bit skeptical at the frequency which they're currently being considered that they're this early. But one way that you can sort it out is there's very little harm in trying hormones for 3 months to see if your symptoms improve. If there's no reason not to take them, it's pretty low risk to just give them a try. Within 3 months, many of my patients will be very clear that yes, these symptoms all got better. My brain fog seemed to clear, my joint pain went away. Others will say, have the same symptoms and say, no change, not worth it, and these hormones are annoying me. Let's move on. You can always stop the hormones and restart them again to see if the hormones are actually improving the symptom. And if they're not improved, then stop them. Look for other reasons. So there's a bunch of myths out there. Adrenal fatigue, how many of you have heard of that? It's really not a thing. It is not necessarily associated with menopause. Adrenal failure does happen to some people. It's extremely uncommon. And usually it's preceded by pretty significant symptoms. Things like a real collapse. If somebody gets sick in your household and you get sick, you get the same cold for 2 weeks and they're sick for 2 days. These might be clues there could be something significantly wrong with your adrenal gland. Very few people have this. Loss of libido is also, it's been associated with the menopause transition over and over again, but it is more closely associated with age than menopause. And it is not linked to testosterone levels as tightly as people might be led to believe. Testosterone levels don't go down with menopause. They actually stay the same. Women have the biggest drop in testosterone when they're in their 30s. So if testosterone was the biggest driver of libido for women, then there really should be a big drop in libido in the 30s, and we don't actually see that. We see the loss of libido at all ages. Progesterone, one of the myths is that you need to have progesterone if you've had a hysterectomy. You do not. The only reason to take progesterone is to prevent an overgrowth of the lining of the uterus if you are taking estrogen. If estrogen is given after menopause and you don't have any progesterone balancing that out and preventing growth of the endometrial lining, that could lead to what's called hyperplasia or even a cancer if it were neglected. And that's the reason to give it. Otherwise, there is no indication to give progesterone, and it may increase some of the risks of hormone therapy. So keep it simple. If you've had a hysterectomy, estrogen is probably all you need. There's a new bunch of literature out there of people that are saying that hormones will prevent heart disease and will prevent dementia in women. This is not based on the best available scientific evidence. While there's some room for debate in this field, and there may be more studies that should be done, we currently do not have good enough proof that it prevents heart disease, and we actually have contradictory evidence in terms of dementia. So taking it for those indications is not recommended. Some studies show that women who take hormone therapy have a higher risk of dementia later in life. So it's not a phenomenal disease preventive. It's great for symptoms, but not for that stuff. Some conditions that affect midlife women that are not due to hormones can be missed if there's an over focus on hormones. Things like fibromyalgia, which typically strike women in their 40s and have different causes that are not well worked out. Chronic fatigue, very similar. And women, unlike men, are more prone to autoimmune disorders. There's a real sex difference here. And those also tend to come up in midlife. So if the simple answers aren't coming readily and hormones aren't clearly the problem, look for other causes. One of the other very interesting things that's just become scientifically available is one of the age-old problems is how can we separate what's going on in the ovary from what's going on in the rest of the body, somatic aging and ovarian aging. These processes seem to be separate in many cases, but a recent study showed that when you look at human aging, these investigators from Stanford looked at what we call multi-omics, and they saw a change in both men and women that was not solely attributable to menopause. They weren't able to link it to menopause. So both sexes are doing this. And notice that this is nonlinear, and I'm about to show you how nonlinear it was. And it's a very intriguing study. It's only 108 people, so it needs to be replicated. But these were people aged 25 to 75. They did a bunch of assessments in each of these individuals. They looked at multi-omics, which I'll show you the graphs of, and they saw dysregulation at ages 44 and at age 60 in both men and women. So this study knocked my socks off because changes are happening related to age at age 45 before the transition in many women, and again at age 60 after the transition. So again, if we attribute everything to menopause, we're going to miss important stuff. And this is how striking the data are, which make me think it is going to be replicated. So when you do multi-omics, you're looking at molecules, you're looking at microbes, you're looking at some commonly done lab tests, metabolome, you're looking at the microbiome in the gut. And every single set of omics that they looked at in these colored graphs on the bottom show the same two peaks, right around those same ages, 40s, late 50s. 45 in lipidomics, transcriptomics, and these are all, when they put all of the significant molecules together, you see these two gigantic peaks. So, you take this omic change when you're in your mid-40s, then you have menopause somewhere around here, which is likely to cause symptoms. It does for most women, and then you get another aging peak. So these can be challenging. One of the other myths that's out there, or one of the other interesting things that's happening in science, is there an independent benefit if we could delay or prevent ovarian aging? If you prolong the life of the ovary, do you prolong a woman's life? We do know that women who get menopause at a later age tend to live a little bit longer. They don't live a lot longer. And women who have menopause early in life tend to live a little less long. But again, this effect size is fairly small. So I remain skeptical about these data, and also remain skeptical because I really wonder to what extent women want to continue using birth control and having menstrual periods well into their 50s or even 60s. So there's probably going to be a better way. But there's some really fun and compelling pictures here. Superwoman, probably from Silicon Valley, so she doesn't ever want to have menopause and she'll live forever. We'll see. And I'm so glad I can continue having periods and worry about contraception until the end of my life, said no one ever. So the uptake of this for the average woman, I would guess, is not really going to be that huge. So let's talk a little bit about hormone therapy and where we are in 2025. The model really is one for symptom treatment. It's not, again, not to prevent disease. And these are really the cardinal symptoms that if one of my patients comes in and she's complaining of any of these things, I can feel pretty confident that hormones are likely to make that better. And hot flashes are the number one symptom. 80+% of women will report them. About 25% of women will report moderate to severe hot flashes that interfere with their lives enough that they really need treatment. Vaginal dryness appears in about 25 to 50% of women. It depends on how you ask the question, and that can make intercourse aversive. So that's actually easy to treat, and just local vaginal estrogen can be used, which doesn't really get into the bloodstream. And that is safe for most women. That can even include women who have had breast cancer, because there's so little of it that gets into your bloodstream. Poor sleep is reported by about 40% of women as they go through the menopause transition. And while some of that is associated with aging, and we know that women do not sleep as well as men do in general, there's a sex difference there. This may be costly to women in terms of health. So sleep is something that is getting more and more attention. And in particular, waking up after sleep onset, what we call WASO, can be a problem. And it seems to cause more cardiovascular disease, more what we call metabolic syndrome, risks for cardiovascular disease in women that have poor sleep. And mood changes, in particular depression and major depression, as women enter that late menopause transition, goes up. All of this symptom gets better as women go through the transition. And once you're done with your final menstrual period and hormones have restabilized and downsized, that depression risk goes away. But that's a risk point for women, particularly those who have had depression before. Women can notice a surge in anxiety, even to the point of panic, again, associated with that late transition. This can be worse in women who've never had anxiety symptoms before. So some women will notice they've never had this problem, and all of a sudden it's become a big problem. And some of these issues can respond to hormones, but sometimes they will need additional therapy or psychiatric medication. And this is, again, possible but not proven protection with early use. And a lot of that's out there sort of swirling in the social media world, is that this is going to prevent heart disease. A far better way to prevent heart disease is to live a healthy lifestyle. And the effect size of hormone therapy is actually quite small. When it has shown up, it does not show up in multiple studies. So it's not a consistent finding, but it does not look harmful. In most cases, dementia, again, as I said before, there's data on both sides of that. So some data show that it's harmful. So not a good reason to take it. So how many women seek treatment for symptoms? This is an old population-based survey, but other surveys around the world have also found similar findings. About 2/3 of women will seek care. They will see a clinician, doctor, an APP, nurse practitioner, for their symptoms. And the most common symptom that drives them into the office are hot flashes. Of those women, about 1/3 use hormone therapy, about 12% use complementary and alternative medicine, 16% use both. But when you look at who's not treated, that's almost 40% of women that don't get any treatment. So they leave the office having gone in to discuss their symptoms with no treatment. And this is important because we're learning new things about hot flashes and how they may be related to disease later in life. And this graph shows you two conditions, two things related to heart disease. So vasomotor symptoms that were reported as being frequent more than 6 days in the past 2 weeks. If they started early in your menopause transition, looking at this graph on the left, then you had thicker, what we call intimal medial thickness. So these are the arteries in the neck that are looked at with ultrasound. Your carotid intimal medial thickness is thicker, meaning you're making carotid plaque. So you're someone who's going to make more plaque. This doesn't necessarily mean if we treat your hot flashes, you won't make plaque, but that study hasn't been done. But it may well be tagging women who are at higher risk, who need to be followed more closely and have their cardiovascular risk factors managed more aggressively. So that's a pretty striking difference. Women with a high level of hot flashes, so the ones with the worst, hot flashes, also had more intimal medial thickness. And when you look here at those frequent hot flashes, and this is from the study of women's health across the nation, we began the study in the 90s, and we followed the women every year for outcomes. So this is a fabulous data set that of longitudinal data that lets you look at disease risk predictors. The women who had the most frequent vasomotor symptoms had significantly higher risk of heart disease, any kind of heart disease. So we know now that this is telling us something about what may happen in the future. So, equipped with that knowledge, women may want to get a little personalized medicine here and have that looked at. Sorry, I'm so twitchy. I think I have static electricity today, so I keep setting off my clicker. Another thing that we see, and this graph just shows you years on the bottom with 0 with the little arrow being when a woman's final menstrual period is that menopause itself is associated with an increased risk of what's called metabolic syndrome. So metabolic syndrome is when you get abnormal cholesterol levels, your good cholesterol gets lower, your bad cholesterol gets higher. It's associated with weight gain, particularly mid-body weight, and also associated with insulin resistance, high blood pressure, and a tendency to diabetes. We have medications to treat all of these things. We have lifestyle interventions to treat them. So these are things that if we know it's happening, and if it gets evaluated carefully enough, can be averted or reversed. So a woman knowing that she's at higher risk, if you've got a bad family history, et cetera, this is something to really look out for and jump on. A few other things that are not lovely that happen with perimenopause is that there's an increase in abdominal visceral fat. And this is almost universal. Most women have this. And you can see there's a slow rate, about 2.3% per year. Then as women go through that transition, and that late transition, again, that speed bump that I showed you, that 2-year period around the final menstrual period, the rate of change in abdominal visceral fat goes up to almost 8%, almost 4-fold higher. And then after menopause, it goes back down. So it goes back down to more of an age curve. So this is, again, a time when something, physiologic changes are so fast that more is happening. And again, when we look at the carotid intimal medial thickness, what's happening with plaque in the carotid arteries in that perimenopausal period, there's a rise, but note that it goes down to a more benign progress after menopause. So again, that year or two around the final menstrual period, you're more likely to run into a lot of these things that will spell out into cardiovascular disease later in life. And this is just looking at the carotid intimal medial thickness with the late menopause transition in green. So that's that 60 to 90 days of amenorrhea. And it goes back down again. So the important message here is it does get worse, but a lot of that is almost a temporary state associated with the sort of hormonal turmoil in that late transition. And another thing that's seen is that the stiffness of the arteries, which is something that puts a woman at risk for hypertension, increases during the transition and then tends to go back down again. So women that are at high risk, this is the time in life when if you have a family history of high blood pressure and you've got the genes, your high blood pressure is going to declare itself. And I see this over and over again clinically in the office where many women will start to have their blood pressure go up and they have a very hard time believing that this is that. But once again, we've got great medications to treat that prevent disease down the road. So if you're going to get it, figure it out early, get it treated. LDL cholesterol does a similar thing right around that transition. It goes up by a certain amount. It looks completely alarming on this graph, but this is not a huge amount. And if you'll notice, all of these women are still have, they're starting to bump up out of the normal range for LDL. And the more of an LDL change you have, the more likely you are to make plaque. So even though we tend to undertreat women with statins, these kind of data tell us that we probably should be thinking about that a little more carefully. And the last really depressing, I think this is my last depressing slide that I'm going to show you, or there may be one more, that again, associated with the final menstrual period, there's universally a small gain in fat mass and a small decrease in lean mass. That does seem to be specifically associated with menopause. It looks alarming, but 100 to, these are a few percentage points. But those of us who have lived through it, it's enough for you to notice. But after that, it tends to stabilize. And menopause on the average is not associated with a large increase in body mass index for the average woman, although it's clear that some women will go on a path where they begin to gain and gain and gain almost uncontrollably. And all of the tricks that they've used prior in their life to lose weight don't work. So this, I believe, is the last one that I'm going to show you that's the most depressing. But this is when bone density begins to be lost. And it's an important slide because clinically, in clinical medicine, I don't think we're doing justice to women who are at risk for osteoporosis because of the recommendations that we live with. But this is those years, the estrogen turmoil years. Bone density is stable until you reach that late transition. So it takes at least 60 days of amenorrhea to start losing bone. So if you are menopausal, perimenopausal, and you haven't yet had 2 months without a period, there's absolutely no reason to look for bone loss because you haven't lost it yet. If you start looking in those years after, there's about 3 to 4 years called the transmenopause, where almost 10% of skeletal bone mass is lost. And that is directly related to menopause. So on the average, that's what women will lose. Many women can sustain that loss, but if you're somebody who began life with not a very robust bone density, or you have a family history, you're going to be at risk sooner. And unfortunately, our current guidelines only recommend screening bone densities at age 65. Unless a woman is at elevated risk. We know that white women are at higher risk, even though Asian women tend to have lower bone density, they tend to fracture less. So those are the two groups that are higher risk. Black women are at lower risk. And you can see from these little lines, no bone loss in premenopause in the blue early, late transition and postmenopause is where bone loss happens in the spine and the hip. So if you are someone who knows that this runs in your family, or have known risk factors, you may be eligible for earlier screening, because I personally don't like to see patients when they come in already over here, having lost a lot of bone and playing catch-up ball, which you don't always know is going to work. I'd rather catch it before the process happens. So let's talk about hormone therapy. There's a lot of different ways to give it. And that's a blessing and a curse because a lot of the way that we approach it is really trial and error. We don't have good knowledge to say, based on your particular set of risk factors, your history, et cetera, this exact preparation is going to be the best for you. But we can almost always find a way that's going to be acceptable. So estrogen is preferred to be given in the naturally occurring form, which is estradiol. And not to be given orally, because if you give it by mouth, it passes through the liver as you digest the tablet. And that causes liver clotting factors and proteins to go up. And that is thought to be related to the higher risk of blood clots and thromboembolism and pulmonary embolus that women who take hormones are at higher risk for. If you don't take it orally, you bypass that liver effect. And the skin patches, this is an estradiol skin patch, is probably one of the easiest ways to give it, although it's not for everybody. Women who have a uterus who need to take progesterone with the estrogen, there's combination patches that give both natural estradiol. These do not give naturally occurring progesterone because you can't put that in a patch. There's an oral form of estradiol and progesterone in a single tablet. There's also just progesterone capsules that can be given. So if you were to take a patch of estradiol and you have a uterus, you need to take that with progesterone. So you would take it this way with the pill. You would take another medroxyprogesterone, another progestin. For people who don't tolerate patches because they get rashes or they don't stick, there are gels, and this is just an estrogen gel that you rub into your arm once a day. And alternative ways to give progestin is with an IUD. So the IUD that has progestin in it is good for 5 years to protect the lining of the uterus against developing hyperplasia or cancer. So that is a very nice way for women who are maybe perimenopausal when they have symptoms who are going to start hormones. It'll give them contraception, it'll protect the uterus, and then they can just add back the estrogen. So that's one way that you can go. And for women who can't tolerate estrogen in any other way, there's a soft, flexible ring that's exchanged every 3 months that can slow release estrogen throughout the body in higher doses. And there is a very low dose ring that just treats vaginal symptoms. So we have a great number of ways to treat. And the risks of hormone therapy are actually, and I consider this good news, they're very well known. So it's not like they're mysterious, and it's not like they're horrible. So this graph just shows you the things that we worry about, that we looked at, that were looked at for years at endpoints in different studies, including the Women's Health Initiative. And this is based on the Women's Health Initiative results, but also some other studies. So if you look at the risk of blood clots, this is using oral estrogen, not transdermal non-oral estrogen. About 12 out of 10,000 women will get a venous thromboembolism in a year if no one took hormones. If women took hormones, that number would go, there would be 8 to 18 more cases. So that's 20 to 30 per 10,000 women that would have blood clots. So that's a pretty substantial increase in risk, but it's a pretty rare event. So most women are not going to have that happen. And we think that by using hormones non-orally, you avoid most, if not all, of that risk. Heart disease, the background risk is 26 out of 10,000 women will have a heart attack or a cardiac event in a year. Depending on how hormones are given, if you have a hysterectomy and you just take estrogen only, there's a small decrease in risk. If you take estrogen plus progestin, and again, this is oral hormones, this is from the Women's Health Initiative, it's an increase. And that goes from 26, could be 23 to 29. So the attributable risk of hormones is really quite small in this case. And depending on the age you are when you take the hormones, this risk can be lower. The risk of stroke, 23 per 10,000. You add 7 to 12 cases, depending on whether you used estrogen plus progestin. On the left, you add 7 cases. This estrogen alone adds 12, and that number can go up. But all of these are quite rare. Breast cancer risk, much higher risk overall in the background, 600 cases of breast cancer for every 10,000 women. That goes up to 608 per every 10,000 women if they took estrogen plus progestin. If you take estrogen alone and you've had a hysterectomy, your risk of breast cancer is lower if you take oral estrogen. It's actually lower. It doesn't make any sense to me. With other forms of estrogen, it goes up, but it goes up to a much smaller degree. So it might go from 600 to 602 or 601. So you can see when you add these up, the risks of hormones are overall low, and they have to be balanced against a benefit. And that benefit is something that every woman will know for herself, because it's going to be her improvement in symptoms. So clinical guidelines really around the world are in good agreement. And these are usually a bunch of experts get in a room, all the data is thrown into a pile, we all digest it and come to agreement. And these can be pretty contentious. So it's no small deal that all of these societies have come to very similar recommendations. And those include, for hormones, the use of natural estradiol and naturally occurring progesterone, the use of non-oral, and for women who don't have a uterus, who've had a hysterectomy, who still have symptoms, they seem to have the best benefit to risk ratio of anyone on hormones. So those women tend to be on them for a longer period of time as well, because they tend to have worse symptoms. And for all women who are using hormones, a periodic reevaluation of the risks, the benefits, and the alternatives is in order, because this field is changing all the time, and we come up with better ways to build a mousetrap. There's also a bunch of non-hormonal treatments for hot flashes, and we owe this to women who had breast cancer who reported back to their doctors when they happened to be taking another medication for another reason that their hot flashes got better. And their doctor then engaged with other women with breast cancer to do some systematic studies. So we have a bunch of medications in the SSRI, SNRI class, and these include these antidepressants. So trade names are Effexor, Pristiq, Brisdel, Paxil, Prozac, I think Celexa, Lexapro, and sleep medications, pain medications. Gabapentin is an anti-seizure medication that's been repurposed for hot flash treatment. Clonidine is a blood pressure medication, and oxybutynin, a medication used for overactive bladder. These have all been studied and provide some relief from hot flashes. The big negative with the ones on the bottom are that they all have side effects. They have off-target effects, because if you don't have depression and you're taking an antidepressant, you can feel a little weird. They can have sexual side effects. Some of them can't be used with other medications. And gabapentin can be great for nighttime hot flashes, but it can make some people drowsy or dizzy. And clonidine can cause a dry mouth and make your blood pressure too low. So while these all have use for certain patients, again, by trial and error, you can usually find something, but not always. Now, one of the new things, and that's at the top, is FDA approved. And you can see only one other thing in this chart shown by the asterisk is FDA approved, and that's paroxetine mesylate, Brisdel. So fezolinetant trade name is Veozah. This was approved about 2 years ago for hot flash treatment, and it is the first in class medication that treats hot flashes in the place in the brain where they originate, and it bypasses estrogen. So it has an efficacy that is comparable to estrogen. It's the first one we've gotten our hands on. There's another one that is pending FDA approval. It's been approved in Europe and Australia, called elinzanetant. Seems to also have a similar level of effectiveness. The downside with fezolinetant is that there have been one isolated case out of 150,000 women who've been prescribed it so far of liver toxicity associated with the medication. The FDA has required monitoring liver functions because women may take this for a long period of time. You want to make sure it's not causing a liver problem. So testing is required for the first 9 months of treatment. So this just shows some of the exciting stuff about the science behind these new agents, because this was a finding that a neuroanatomist in Arizona made. She found these neurons that are called, well, she didn't find these neurons, they were known, the candy neurons in the brain. And they have a receptor on them called a neurokinin 3 receptor. So what you can see here is neurokinin is activated. Estrogen, when it's low, you don't have enough estrogen around, that causes more activation of this neurokinin pathway. And both in the candy neuron in the hypothalamus and another neuron in the median preoptic area of the brain, which is the body's thermostat, the settings go a little haywire. And you can see red woman over here is just having a booming hot flash. So her thermoregulatory center has triggered the sweating heat dissipation reaction. Now, if you antagonize the NK3 receptor, and this was done by antibodies, in animal studies, and now fezolinetant or Veozah is shown here, you abrogate that whole signaling pathway. So you do the job of estrogen. Estrogen is actually acting here, but the NK3 receptor antagonist is acting here. It blocks this at both locations, and you can see that the formerly red woman is now nice and cool, and her hot flashes have improved. I want to just spend a couple of minutes, because I know we're going to have questions, about bioidentical hormones and compounded hormones because it's a very big thing. And I've noted in Colorado, I used to practice in New York, it was less of a big thing. Pellets and the like all fall under the category of compounded bioidentical hormones, which are naturally occurring estradiol, progesterone, and testosterone. But the National Academy recommends against them. They are not regulated by the FDA. They have no need to prove the efficacy or safety. The proof of claim is much less rigorous for things that are considered dietary supplements. And they have been considered supplements for years and years now. Many people who sell them have huge conflicts of interest that are not declared. The medical evidence is scant. So this report came out in 2020. Testosterone, another big thing, and pellets, again, a very, very big thing in Colorado. And my joke is, do women need testosterone like a fish needs a bicycle? There's a tremendous mystique about testosterone causing, being fantastic for libido. There are reasons to be skeptical. There's, first of all, no defined testosterone deficiency syndrome in women. And there is actually an experiment of nature, which we look to in endocrinology a lot to teach us. There's a condition where the testosterone receptor in the body doesn't work. So the body cannot process a testosterone signal. People with that problem are phenotypic females, and they do not have a deficiency of libido. And their sex lives are not horrendous as a result of this. So this is no testosterone action at all. So the brain is a much, much more important sex organ. It's not entirely susceptible to testosterone. There's no measurable level of testosterone that a woman has a problem. Patients bring me tests from all sorts of places telling them their testosterone is low. This is just it's not a thing. It's not a syndrome. There's also, as I mentioned before, no drop in testosterone at menopause, but boy, is it a big business. There's also no abrupt increase in sexual dysfunction that's concentrated around menopause, yet that does not seem to be the case if you were to look in social media. There's also no FDA-approved testosterone preparation for women. There's one evidence-based indication, and that is for hypoactive sexual desire disorder. It can be helpful for some women using either compounded testosterone, which I just told you was not a great idea, or a fraction of male dosing. And it is a controlled substance, so it's a little tricky to give it. But I do have some patients who take it and find it helpful. Many do not. And this is pellets, disinformation highway. If it's a supplement, there's no need to support a proof of claim. And in particular, pellet hormone therapy has been looked at, and it increases patient and healthcare system costs, more bleeding, more abnormal hormone levels, because you can't control the levels that are in the body once you put that pellet in there. So beware. So to sum up, menopause is definitely having a moment. We need to move beyond the hormone deficiency model that women are somehow deficient for having menopause and they need to be replaced. It's really a way of looking. I think we need to look a longer term strategy that uses a little bit of precision medicine for our patients and embraces a continuum of responses to aging, to reproductive aging, and to look at all these other physiologic things that are happening and deal with them. But again, as I said in the beginning, no need to suffer in silence with menopausal symptoms. They're not fun for most women who have them. And there's plenty of treatment options, and there's almost always a way to treat. And we've got some new cool options for hot flashes. So for people who have not or have shied away from hormones, there's other ways to treat it. So with that, I'm going to stop my share. And thank you for your attention, and go on to some Q&A. I see we've got a few in there already.
I'm going to go ahead and read them to you. Dr. Santoro.
Okay, great.
Can you speak to using estradiol and micronized progesterone in postmenopause state when having no menopausal symptoms, pros or cons? That question came in really early, like
Okay.
about 5:10.
That's really there's some people out there promulgating the use of hormones as a preventive medication. And I would say that there is not adequate scientific evidence to do that. I think that you could actually do more harm. So even if it is natural, even if it's, the exact preparations that you mentioned, there is not good long-term evidence to say that you are going to prevent disease. There's a couple of signals for heart disease from the Women's Health Initiative study that women in their 50s who took them for symptoms had a lower risk of heart disease, but that was not what's called a pre-specified endpoint. So in clinical studies, in a clinical trial, there's a saying, if you torture data, you can get it to say whatever you want. If you do enough analyses, something's going to turn up. So was that finding something that turned up, or is it real? There have been two studies on the heels of that finding that have tried to look specifically at carotid intimal medial thickness, plaque in the neck, and calcified calcium in your coronary arteries. Those are two signs of plaque. I was involved in one of those studies, which was called KEEPS. We treated women for 4 years, neither micronized progesterone or natural estradiol or oral estrogen, like given in the Women's Health Initiative with micronized progesterone. Neither treatment, we saw no difference after 4 years in plaque. We saw no difference in coronary calcium. Another study done on the West Coast using a very similar design, but they used oral estradiol, saw a slower rate of the arteries in your neck getting plaque in women who took it early after menopause. So that is not the same thing as looking 10, 20 years later at who gets heart attacks. But for me, that's not good enough proof to recommend that the women of America should be taking estrogen and progesterone to prevent heart disease. It's a big commitment. It may give you bleeding. You may get other side effects. You are going to have other risks. And this is not a proven benefit.
Great, thank you. Next question. For the progesterone IUDs such as Liletta and Mirena that are now approved for use up to 8 years for contraception, is the 5-year recommendation for the use in hormone therapy because hormone levels beyond that are not sufficient to provide endometrial protection?
Yeah, it's a great question. I think that the Mirena probably is good for all 8 years and probably even longer because the amount of estrogen that you give in hormone therapy is pretty low. It has only been tested for 5 years. So that's what you can feel secure about. For patients that I have that are on it for more than 5 years, I will sometimes let them go for a little bit longer. And if they do have any bleeding, we'll evaluate them with an ultrasound. So that's another way to maybe cope with that. The amount of estrogen in your bloodstream when you're taking hormone therapy doses is about 35 to 45 picograms per milliliter. That's equivalent to what your estrogen level was maybe on the first 3 or 4 days of a menstrual cycle. In a normal menstrual cycle, it goes up as high as 300 to 400. And after menopause, if you took no hormones, it would be usually below 10. So it's not very high. I think it would just take a little touch of progestin in the uterus to prevent it, but that's the best evidence that we have right now.
Next question. If VMS are treated with non-hormonal medication, does that decrease their CV risk over time? And do you know why women with VMS have a higher CV risk?
Yeah, so it's not known, and that study that you're proposing has not been done, but it deserves to be done. Does this mean that if you stop them, you'll reduce the heart problems? It's probably identifying, like the big bad hot flashes are probably identifying somebody whose blood vessels are more reactive than the average person. And that is putting them at risk for coronary spasm, possibly for more plaque later in life. That's my guess, if I had to guess. So I think it's someone who should be followed carefully for cardiovascular risk factors and should be treated aggressively with treatment to prevent hot flashes because it may be an improvement. It can't be good for you to have hot flashes. Like they just don't feel good.
How do you approach MHT for patients with symptoms, hot flashes, etc., who are still having frequent periods?
It's really tricky when you're having frequent periods. I'm actually writing a grant right now to try to do a practical real world trial to treat this. My preference, there's a lot of good ways that you can try. My preference, and a lot of female OB-GYNs are very comfortable with, but a lot of other people are not, is to use a progesterone IUD. It reduces bleeding. About 20% of women won't have periods at all. And then they can dial in estrogen as they need it. This can be very helpful for people who have menstrual migraines, for example, because menstrual migraines typically get worse in perimenopause and will get better after. But that progestin IUD will protect your uterus. Any dose of estrogen is okay, so you have a wide range of doses that you can give. And the patient can, if her hormones feel high, she doesn't have to use it that month because they will go up and down. And some of my patients are very sensitive to that. And it's a low enough dose that it doesn't really matter if you go on and off it. And if your uterus is being controlled with the IUD, you're not going to bleed. For other women, the IUD is just a headache. It gives them breakthrough bleeding and spotting. And they're a lot trickier. So the only other thing we have in our trick bag now is to put somebody on continuous birth control pills or the patch or the ring. So continuous combined hormone contraception, but don't take a break. Don't take that week off. It's been shown that when perimenopausal women take that week off, they get a rebound of hormones afterwards, and their hormones get too low in the week off. So they get symptomatic and they can get ovarian cysts and just be uncomfortable. So you've got to take it all the time, and that's kind of putting you at a high dose hormone clamp. And that's also problematic for some women because some women can't take that. Their blood pressure will go up. They don't like how they feel on them. But for women who that works for, that can be a godsend. Other solutions are a little trickier, so we may try one of the non-hormonal treatments to see if that's going to work. Even though Veoza is just approved for postmenopausal hot flashes, you can still use it in perimenopause, even though it's technically off-label.
That is our last question in the chat. If anybody has anything to put in, go ahead and type it in. We've got a few more minutes left with Dr. Santoro.
Well, I see a couple of good ones.
Oh, I'm not in the Q&A. That's why. I'm over in the chat. Oh, goodness gracious. All right, you ready?
Uh-huh.
If autoimmune disease affects women at a 9-to-1 ratio and emerge often during menopause transition, couldn't we make a leap that estrogen plays a role in immune modulation regulation?
Yeah, it's quite possible. And people have looked for that. And it's clear that with some conditions, things like lupus, there's a relationship to hormones, but it's not uniform. So there's other patient factors that are related to it. We know in pregnancy, it's the rule of thirds. It gets worse in a third, it gets better in a third, it stays the same in a third. And that's true for many of these autoimmune conditions. So for some of my patients who have, for example, rheumatoid arthritis, they get much better on hormones, and others will find that it aggravates the condition. So it's kind of like you don't know until you try. But are there biological relationships? There may be. There's also some other fascinating theories as to how women get sensitized.
What treatment options are available for women with hormone receptive breast cancer and using tamoxifen?
So Veoza is really helpful in women that have that condition. I've also had success with some of the SNRI medications, and usually that's one of the ones I'll go to first. The good thing about the antidepressant class of medications in this treatment, and also with Veoza, is that the relief is very fast. It's within days. So it's not acting like an antidepressant, which takes weeks. It starts to act almost immediately, so it's acting through a different mechanism. If the hot flashes are worst at night, then sometimes gabapentin may be all that's needed because that will help you sleep. And it's if you get a little bit drowsy from it, no big deal. Some people will just get dizzy from it and just don't like how they feel. So that can be a problem.
Are we drawing labs to confirm menopause?
There's no need to draw labs for most women to confirm menopause. So a panel of laboratory tests can really be misleading in this case, especially if you're perimenopausal. So it's a little bit like women's hormones across a normal cycle. I mean, they are cyclic, so they change, and they change more than tenfold over the course of a cycle. Progesterone changes more than 100-fold. And that will change your other hormones, LH and FSH, that we look at to try to tell us where a woman is. So if I test your hormones today, it's kind of like trying to figure out how fast your car was going on the highway that you were driving on, 8 hours ago. It's not particularly informative. And in fact, it can almost be misinforming, because if I look for an FSH level to be high, but you've told me you haven't had periods in 3 months and you're having hot flashes, but that particular month you happen to have a cycle, your FSH could come back low. I still know you're perimenopausal. It hasn't changed your diagnosis. So the blood test isn't particularly helpful in many cases.
Is there an age limit or maximum length of time for using HRT?
It looks like for women aged 50 to 59 who are at average risk for most diseases, um, it's reasonable to continue hormones for that length of time. You begin to see, since breast cancer is such a feared and terrible disease, even though what I showed you is a relatively small risk, I don't think it should be dismissed. So after about 4 years on hormone therapy, the women who took estrogen and progesterone separated from the women who did not. You could see an increased detectable change between the two groups. And there was a little more breast cancer in that group. That's the point at which I usually will advise my patients to think about tapering or trying to get off. Many can't. We know that the average experience, the median duration of hot flashes is about 7 years. So if you start taking hormones right away, they make your hot flashes go away. You're probably going to have them for about 7 years. You're going to pass that 4-year point. You may be taking on a little more breast cancer risk, but there are other health benefits that you're going to get, and you won't have hot flashes. So it may well be worth it for that decade. When you look at the outcomes, they look overall favorable for women aged 50 to 59. And this is even from the Women's Health Initiative that everyone always bashes as saying hormones are terrible. Women in their 60s also looked relatively neutral with hormone therapy, although that duration of hormone use, again, if you have a uterus and take estrogen and progesterone, does give you an increase in breast cancer. Your overall mortality did not differ from women who took hormones if you took it for a mean of about 7 years. So that's not such a bad deal. So some women may want to go on it for extended use. By the time you get into your 70s, it looks like there's a little more harm that can outweigh the benefits. So it would be ideal to get off them by like 60s, 70s. And most women, if you don't have symptoms anymore, you can stop. And many women will have no more symptoms and they're done. I do have patients in my practice whose symptoms will never go away. That's about 3 to 5% of women will have them well into their 70s, 80s, and beyond. And if nothing else works, you may wind up taking hormones at those later ages because your life is just miserable. Your quality of life is terrible without them. But it is worth trying these other things to try to get off them because they can accrue some risks over time.
What are most perimenopausal women using for contraception? And when should they feel comfortable discontinuing use for low chances of pregnancy if used for contraception purposes?
Yeah, it's a great question. Well, I think about 40% of women use sterilization, either themselves or their partner. So if that's the issue, then contraception's not a problem. Um, you're not 100% sure until you're an entire year without a period that you're really kind of done. Although the probability of pregnancy goes down very dramatically once cycles become irregular. It's about 1 out of 1,000 probability of pregnancy, but we don't really know in that age group how hard those women are trying. They're probably trying not to get pregnant. So it really isn't 100% safe to discard contraception until you reach that point. And that point can be impossible to define if you're taking birth control pills up until the end of your uh, reproductive years. So what I will do with my patients is we'll usually have them stop the pills, watch to see if they get a period, and in the meantime, use some other barrier type of method of contraception. Condoms probably going to work pretty well for you at this point because fertility is overall low, but they have a failure rate.
Do you have a limit HRT for women with dense breast tissue?
I don't. Dense breast tissue increases a woman's risk of breast cancer, and it's not an insignificant risk factor. So those patients will usually fall into the higher risk breast cancer group that will try to limit their duration of hormone use. But we don't have enough data to tell us that we're doing anything that's, more than just additive risk. And the risk is modest with hormone use, and it's slowly accruing.
We're going to take one more question, so I appreciate all of you and all your questions that are in the chat. It was mentioned metabolic syndrome. Is it accurate that many symptoms, weight gain, are related to metabolic syndrome and not directly related to menopause?
Yes, it's absolutely accurate. And this may be aging related because some of those changes, when I showed you those omics slides in the mid 40s, the changes were all related to metabolism. So the biggest changes they saw there in the 60s, it was related more to immunity. So some women may take a hit on their metabolic health. Ed Melanson is a researcher at CU who's doing very interesting work on this because he thinks the estrogen related effect and why weight loss, weight control becomes much more difficult for so many women is that we lose what's called metabolic flexibility. And this resonates with me and it resonates with my patients very nicely. So when you were younger, if you ate a little more, like say you go through the holiday season, you eat more food, your body forgives you. It kind of burns, it'll just like make more heat. It'll burn some extra calories for you because it wants to get you back to that set point. If you try to lose weight by reducing what you eat, your body will cooperate to a point and it will lose weight. That loss of flexibility means your body fights you on both ends. So you eat a little more, you gain, and it's not coming, it does not want to come off. So you try to lose, you reduce calories, you've got to be much more drastic and sustained, and it to the point where it becomes almost impossible. And when you have metabolic syndrome and you're insulin resistant, that means your body's going to fight you tooth and nail to drop weight, which is why some women notice that their weight will tend to creep up and up and up and can become very, very frustrated because they're repeatedly given the message that, they're failures at behavioral weight loss, which we know is 95% unsuccessful anyway. So now we actually have medications that work. Thank goodness.
Well, that's awesome. So we're gonna thank you again, Dr. Santoro, for being here. That was a wonderful presentation. On behalf of our attendees tonight and CU Anschutz alumni, I want to thank Dr. Santoro for sharing her time and expertise, and I'm sorry we couldn't get to all questions. Before we close this evening, I want to share the information on the slide for a couple of upcoming events for our alumni community. We will share information, these events in a post-event email. And thank you all again for joining us tonight. We appreciate you tuning in and for all you do for your campus and community. So everybody, have a great evening, and we hope to see you soon again.